yung pattern ng breathing niya, yung lung compliance niya, elastance ng lungs niya, lahat yan sa ating ventilation. On how effective yung kanyang lung function to take in oxygen and move out carbon dioxide. And we also are assessing the oxygenation of the patient. Napakarami niyan. The PaO2, SpO2, okay, yung total oxygen content, and others. Okay, ventilation perfusion, mga ganyan, shunting. So lahat yan sa oxygenation. Oxygenation, of course, is yung ability to take in oxygen from the lungs to the red blood cells, and from the red blood cells to the tissues and to the different organ system. Okay? And number 3, of course, is yung circulation. So sa circulation, ina-assess natin yung movement ng blood through the heart and the blood vessels. So ano yung tinitignan natin sa circulation? Kung okay ba yung skin color niya, kung okay ba yung, kung wala ba siyang pedal edema, okay? Kung may nail clubbing, may kinalaman yung nail clubbing dahil kulang na yung kanyang oxygenated blood na nagsisirculate sa distal part of the extremities. Also, with circulation, dapat natingnan natin yung effectivity ng kanyang body systems, the cells and the tissues para mag-circulate ng oxygenated blood. Okay? So, dyan sa circulation, papasok din dyan yung other electrolytes and yung amino acids na natitake natin for the good circulation. And then, the 4th body function is, of course, perfusion. So, sa perfusion, ina-assess natin yung blood, kung paano siya mag-force or mag-flow ng forcefully through the network of the microscopic vessels. So, within the biologic tissue niya, effective ba? Okay ba yung kanyang exchange of gases? And then, may kinalaman na dyan, i-assess na natin yung kanyang molecular activity ng flow ng oxygen din doon sa from the molecules ng oxygen molecules papunta doon sa across the semi-permeable membrane. Yan, lahat yan ma-assess natin sa perfusion. Okay, so I added this one dahil itong isang unang nakalagay kahapon, these are your functional classification of dyspnea from grade 1 to grade 5. Now, ang American Thoracic Society, naglabas sila ng severity scale of dyspnea from 0 naman to 4. So 5 levels din. Kaya lang magkakaiba yan doon sa doon sa stops for breath after 100 meters. O parehas naman sa grade 3 din siya. Kaya lang magkakaiba siya doon sa level of respiratory distress. Okay? So here kasi, sabi ko kahapon, the grade 1 and 2 would be for mild respiratory distress. Okay? Grade 3 would be for moderate respiratory distress. And grade 4 para sa severe respiratory distress. And yung grade 5 niya is for very severe respiratory distress. I think mas reliable to as compared to American Thoracic Society kasi ang grade 4 nila, which is very severe, meron pa bang very, very severe? Kasi grade 4 niya, housebound or dyspnea when dressing or undressing. Dito, sa grade 4 yon, becomes breathless while dressing or talking, that is under severe. Pero sa kanya, very severe na. Meron siyang mas severe pa, di ba? While at rest, may difficulty of breathing, then that is very severe. Anyway, tingnan nyo na lang kung yan ay lalabas sa exam at ano yung better choice. Kung meron siyang 0 to 4, then they are using the American Thoracic Society. And kapag grade 1 to 5 naman, then they are using the functional classification of dyspnea in general. Okay? Next, we have under objective findings pa rin tayo as we continue in the 4 clinical assessment procedures. So as respiratory therapists, we are only focusing on the chest lung mechanism. Pero, tinitingnan din natin yung extremities niya for circulation and for perfusion and oxygenation, di ba? Kaya, kasama yan sa inspection natin. Pero sa palpation, percussion, and auscultation, lahat yan sa thorax, sa chest and lung assessment. But for inspection, kasama na dyan yung nose, nasal clearing, central or peripheral, cyanosis, digital cladding, pedal edema, okay? Kung may malakas ba yung kanyang pulso, dorsalis pedis, sa kanyang popliteal and others. Okay. Now, in the picture, again, you have to apply yung inyong knowledge on the lines of orientation. So for the mid-clavicular line, anteroaxillary line, these are the landmarks for the precordial exam in the A, aortic, P, pulmonic, T, tricuspid, and M, mitral. So, kapag nagsususpect ang cardiologist sa mas deeper na cause ng cardiac problem niya, nag-auscultate siya in these areas sa aortic, pulmonic, tricuspid, and mitral. Okay? So, ito yung ating landmark. Point of reference natin from the suprasternal notch. Okay? Yung notch na meron ditong curve followed by the manubrium. Andyan na yung ating sternal angle after the manubrium. So, in that level, sa manubriosternal joint, we have from the right parasternal line, yung ating A, aortic for A, and P for pulmonic. Diyan natin ino-auscultate. Okay, kung may maganda bang lub-dub sound dyan. And then, yung tricuspid natin in this area, along with the mid-clavicular line, medyo nasa pang ano na to? Nasa pang fourth na siguro to. Fourth intercostal space. Okay? And then yung mitral valve naman na to, kailangan nating i-evaluate dito with our stethoscope. Okay? Medyo malapit na siya sa anterior axillary line. Okay, so that is under inspection, palpation, and percussion and auscultation of the heart. Then, we also have this under objective findings, yung physical examination niya. So, typical format for physical examination, yung initial impression again. Sa initial impression, yung age, yung kanyang height, weight, sensorium ng patient mo, general appearance. And then yung vital signs niya, assessment mo ng head, ears, eyes, nose, and throat. Okay? Huwag na natin yung isama sa neck, inspection and palpation findings. Kung merong presence of jugular vein ba yan? Okay? Anong ibig sabihin nun? Baka naman merong problem sa heart yung patient natin. For the thorax, we are applying the IPA. For the abdomen, we are applying the IA, percussion, and palpation. And extremities, we are inspecting and palpating para makita natin yung mga relevant findings. Okay, so ito lahat yung ating ine-examine for the inspection as RT. So breathing pattern is the tidal volume normal within 7 to 9 ml per kilogram in Asian or 5 to 7 ml per kilogram. Iba kasi, and 8 to 10 ml per kilogram for Caucasian. Then we will be able to assess the respiratory rate, compute for the minute ventilation, kung nakuha na natin yung dalawa, and then assess for IE, is the breathing rapid, slow, regular, shallow, deep, thoracic breather ba, diaphragmatic breather ba yung patient natin? Is the patient using pursed lip breathing or using the accessory muscles during breathing? Okay? So under inspection, we are also configuring yung kanyang chest shape. So sa chest shape niya, napag-aralan natin yung different chest deformities. Is the spine straight or not? And then during breathing, was there a symmetry of the movement of the chest? Parehas ba na umaangat during inspiration? Parehas ba na bumababa during expiration? Or kung merong asymmetrical chest expansion. So when we say asymmetrical chest expansion, yung isa umangat, yung isa nag-lag behind. Okay? So there is chest lagging on the right. So ibig sabihin, yung left niya ay nagpa-function. So there is asymmetrical chest expansion. So affected part is the right. Right lung or right upper lobe, right middle lobe, or right lower lobe. Okay? Then we are also checking if the breathing during the time is regular or paradoxical. Pag sinabi mong paradoxical, that is during inspiration, instead na mag-descend, bababa yung diaphragm, nag-a-ascend siya. During inspiration, instead na mag-move outward and upward, yung kanyang ribs, pumaloob, pumasok. And there is intercostal retraction, subcostal retraction, or supracostal or suprasternal retraction. Okay? So that is paradoxical breathing. Okay? Under palpation, we are also palpating for the chest excursion. So for the chest expansion measurement, CEM is for chest expansion measurement. So we are checking the measurement of the chest in the angle of Lewis area. So check natin yan. Nilalagay natin yung dalawang thumbs natin doon sa manubriosternal joint or angle of Lewis or sternal angle. And then for the xiphoid process, sa baba na yan, di ba? Doon tayo naglalagay sa below the breast level. And then for the 10th rib, nilalagay natin yung kamay natin halos doon sa lateral area. So ano yung chine-check natin dyan for chest expansion measurement? That during inspiration and expiration, dapat ang difference niya would be 1 to 2 centimeter at the angle of Lewis. Ibig sabihin, nag-expand yung kanyang chest because of increase in the volume of air. If the patient would be able to increase it more than 2, then that is better. Ibig sabihin, nagdo-double, kaya niyang mag-double or triple the tidal volume. Okay? Then at the xiphoid process, using, yung isa during ano lang sa angle of Lewis, pwedeng kamay lang. Tapos, yan, ruler, kung ilan yung kanyang difference during inspiration. So, the patient is instructed to inhale deeply, i-measure mo na yon. And then, blow fully, exhale. Yan. I-measure mo yon kung ano yung thumb to thumb difference. And then, for the xiphoid process level, dapat gamit tayo ng tape measure. So, we wrap around the tape measure in the patient's chest and then ask the patient to exhale fully. Labas muna lahat ng hangin. Okay. And then, tingnan natin kung hanggang saan yung centimeter niya. And then, ask the patient to inhale deeply. Pag nag-inhale deeply siya, aangat yon, di ba? Okay? So, i-measure mo yon. And then, ask the patient to exhale fully. Okay? So, kung may difference pa rin, yung nag-exhale as compared to dun sa start ng inspiration niya, i-adjust mo pa rin yung tape measure at isama mo yung centimeter na yon. So, a difference of 2 to 3 centimeter is normal. And beyond that, kaya pa nga ng pasyente mo na mag 5 centimeter difference kung i-double, triple niya yung kanyang tidal volume. And on the 10th rib, sabi ko nga, medyo dun sa lateral area na o dito sa gilid ng kanyang chest, okay, difference of 3 to 5 centimeter using your tape measure. Okay, in the palpation, you are also doing the test for tactile and vocal fremitide. Okay? So dito, nakalagay dito, decreased tactile fremitus in general. ano yung mga causes. Memorize nyo to. So yung decreased tactile prenitus, possible yan sa mga COPD, tumors, thickening of the pleural cavity, pleural effusion, those with pneumothorax, muscular or obese chest wall, pwede rin decrease ang kanilang tactile prenitus. So ganito ginagawa, oh. So ilalagay natin yung ating kamay dyan. Tatlong area yan. Above the nipple area, below the nipple area, at saka doon sa gilid ulit. And then, we ask the patient to say, stress, stress, stress. Ask the patient to say, SSS. Or ask the patient to say, 99. So, from the upper lobe, i-compare natin yung right and left. Hindi mo pwedeng sabihin na decreased tactile prenitus lahat. Saan? Dapat may comparison lang because we will never know kung merong decreased tactile prenitus sa left lang lahat. Okay? Or, kasi isa-isa yan na chinecheck mo. Imposible na maging accurate ka dyan. Okay? You can only check it, test the upper, right and left. Okay? Middle, right and left. And lower, right and left. Kung saan may increase or decrease in tactile prenitus. So take note of the increased tactile prenitus. What are the possible conditions? There is alveolar consolidation, like in pneumonia, alveolar collapse, pulmonary edema, lung tumors, pulmonary fibrosis, or those with thin chest wall. Okay? Now, under palpation, na-assess din natin kung meron siyang crepitus. When we say crepitus, baka nagkaroon siya ng subcutaneous emphysema wherein nafe-feel mo dun sa skin niya na during inspiration, parang may mga nafe-feel ka na bubbles dun sa loob. Okay? So, this is due to anong mga causes niya? One is, of course, may subcutaneous emphysema siya. Sumabog na yung bleb or bullae niya and then pumasok dito sa subcutaneous area, the tissue beneath the skin. Okay? Doon nagkakaroon ng trapped air. So that during palpation, bakit parang may gumagalaw? Okay? So you will suspect for nodules, kaya or meron siyang tumor doon. Okay? But actually, yun ay crepitus from a subcutaneous emphysema. Okay? Then, further sa ating clinical procedure, tapos tayo sa inspection, palpation, and now we are in the percussion. So this one is percussion during physical examination during doing your clinical procedure. Not percussion doon sa CPT or doon sa pulmonary rehab na CPT. Ito yung percussion from this area, below the clavicle, left clavicle, and then piniplace natin yung ating non-dominant finger doon sa intercostal space. Okay? Between doon. Basigsag yan eh. Parang pina-follow yung pattern ng old auscultation method. Pasigsag from 1, 2, 3, 4, 5, 6, tapos sa gilid, 7, 8, then sa baba, 9, 10. Meron yun, di ba? Nababasa niyo yun. Okay. So yun, magpe-percuss ka ng ganyan. So ito yung iyong dominant finger, percussing. Parang ang hirap Ang hirap marinig kung yan nga ba ay merong resonant sound, dull sound, hyperresonant. But pagka-resonant, since normal naman yung chest mo, try mo kung ano yung tunog na pwede mong marinig. And for dull sound, pwede mong i-percuss yung iyong binti. Okay? For the dull sound. Ganyan yung tunog. Pagka sa flat sound, pwede mong i-percuss yung table. Ganyan yung flat sound. Parang medyo may matigas nga. And hyperresonant, pwede mo, or tympanic, pwede mong i-percuss yung stomach mo, yung tiyan mo. Ganyan, parang parang may kabag, ganyan ang tunog. Now, the normal percussion finding in the chest area, lung area, is what we call as resonant sound. So the resonant sound is loud, low pitch, long duration. But take note na hindi resonant sa cardiac area dahil siya ay may muscle tissue doon. So that is cardiac dullness, still normal. There is dull or overlap chest doon sa gastric space niya. Pwede rin niyang mag-appear na resonant sound. And doon sa liver niya, liver dullness. Pero normal yon dahil nga affected lang nung underlying organs. Okay. Now for the dull sound, ito yung pleural thickening. Ano yung mga cases? Pleural effusion, atelectasis, consolidation, so there may be tumor, paralyzed diaphragm. So the sound is a float or soft, high in pitch, and short in duration. Okay, so that is dull sound. So ito yung percussion na ginagawa niya. Okay. Now, for hyperresonant naman, madali lang lahat ng may mga trap gas like in pneumothorax, emphysema. Yan, pwede yan magkaroon ng tympanic or hyperresonant sound. Okay? So again, the normal percussion finding is resonant sound. Abnormals are dull or flat, hyperresonant or tympanic. And the fourth clinical procedure during physical examination is auscultation. So as respiratory therapists, we must be very particular in assessing the lung sound, the airway sound, or the voice sounds. So there are normal and abnormal breath sounds and lung sounds. Also with voice sounds. Okay? Kasi after ng IPA, papasok na yung laboratory test. Yung mga laboratory test natin, chest x-ray, bedside spiral, cough, ABG, yan ay related lahat doon sa paggawa natin, document natin ng kanyang SOAP. Now, for auscultation, we will discuss it further. Yan. So, auscultation is a normal breath sounds and adventitious breath sound. Okay? So, pwede rin naman yung ating voice sound, ina-assess din natin. Okay, what happened during auscultation over the trachea? Ano yung ma-assess natin doon? Over the trachea, compatent naman yung kanyang airway at meron siyang high pitch and loud intensity. So that is tracheal breath sound. So that is normal na breath sound niya. While pag ang diaphragm ng ating stethoscope ay nilagay natin around the upper part of the sternum between the clavicle, ay makakarinig tayo ng moderate pitch, moderate intensity sound, and that is broncho-vesicular sound. Okay? Meron pang isa, yung tracheobronchial sound. Ito tracheal sound ito. Meron pang TB, tracheobronchial sound. Kapag ina-assess natin ang kanyang airway, we are assessing the tracheal and the tracheobronchial. Airway lahat yun, di ba? And kapag ina-assess natin ang kanyang airway with part of the lungs, broncho-vesicular. Okay? So around the upper part of the sternum between the clavicle, yan, broncho-vesicular breath sound. And if we are auscultating the peripheral area or the lung area, okay, ang normal finding dapat ay vesicular. So this is low pitch and soft intensity. Okay, again, apat yan. The tracheal breath sound, the tracheobronchial sound, the broncho-vesicular sound, and the vesicular sound. Okay, so these are the adventitious or abnormal breath sounds. So yung RALs ngayon tawag, dati crackles yan, pero still, crackles pa rin naman yung sinusulat nila. So if you here, discontinuous, coarse, and often cleared with cough and heard anywhere in the lungs, that could possibly be rales or crackles. Dahil sa mga cases ng pwedeng atelectasis, kung fine yon, pneumonia, fibrosis, pulmonary edema. Ang dami niyong i-memorize, no? Ng mga diseases during your assessment. Okay, so sa medium naman, pwede yan sa bronchioles. So bronchitis, emphysema, pneumonia, pulmonary edema. So all in all, lahat ito ay due to accumulation of secretions. Okay? Kaya meron siyang crackles or crackling sound. And the types of crackles, merong inspiration and expiration crackles, early inspiration, and late inspiratory crackles. Okay? Ang dami. Hopefully, hindi lumabas na itong detailed ng crackles. Okay? But just read this one. Baka effective pa yung inyong photographic memory. Nabasa ko yan. Yan yung tinatawag na instinct. Kasi nabasa na daanan ng mata mo kasi. Okay? Kaya parang may idea ka. Yun. Yan. Then we have here bronchi. So crackles, bronchi, wheeze, and stridor. Bronchi, galing yan dito sa mga meron siyang low-pitch, continuous bubbling sound at the central or larger airway. So bronchi yon, like in foreign body obstruction. So try nyo yan kapag nakakita kayo ng pasyente na may foreign body obstruction and bronchi yung maririnig natin. So, dapat na-check natin yan sa central or larger airway. Nakarinig tayo ng coarse, rattling sounds, low pitch, continuous, and bubbling sound. Okay. Your bronchi is sometimes called as sonorous rales. So, heard equally well during inspiration and expiration. Okay, ang daming tawag. And then wheeze. Wheeze, alam natin yan, pang-asthma yan, pero hindi lang yan pang-asthma. Lahat ng cases na merong bronchospasm, meron ding foreign body obstruction na nag-react na yung iyong pulmonary defenses at nag-produce na ng secretions din. So pwede na magkaroon niya ng wheeze. For patient with mucosal edema, bronchial mass, or lung cancer. So makakarinig tayo ng musical rales, sibilant rales, sibilant bronchi. So yung wheeze, para ring description, detailed ng sibilant bronchi under wheeze. Okay, parang labo-labo na, no? But yan actually yung mga nasa books, yung other terms for bronchi and wheezes. Okay? The fourth adventitious sound is a stridor. So whenever na nakakita kayo ng croup, epiglottitis, or dahil post-extubation, meron niyang stridor. Possible na magkaroon siya ng stridor. Okay? This is a high-pitched growing sound. Yung parang tahol ng tuta o ng aso. Upper airway often occur during inhalation. So, parang pagka nag-inhale siya, parang gumagano. That is stridor. Then we have pleural friction rub. Yung pleural friction rub is low-pitch, coarse, grating, or crunching pleura. Ito yung nagra-rub yung dalawang pleurae. The visceral pleura and the parietal pleura. So ito yung, di ba, yung nakakita kayo na this is likened to the scratching of your bag doon sa sopa na leather. So, leather to leather, yan, pag pinagkaskas mo, that will create a pleural friction rub. So, in cases of pleurisy, in cases of, yung PTB na to is severe type na ng PTB. Magkakaroon ng pleural friction rub. Severe type of pneumonia na, okay, cancer, and pulmonary infarction. Wherein, nadamay na yung kanyang visceral pleura and nagdikit na doon sa parietal plural. Okay. Number 6 is squawk. Ewan ko kung naka-encounter na kayo ng squawk. This is maybe heard during inspiration, a musical sound associated with diffuse pulmonary fibrosis and hypertensive pneumonitis. Hindi ko pa narinig ito eh. But just take down notes of the diseases that could give you a squawk breath sound. Diffuse pulmonary fibrosis and hypertensive pneumonitis. The seventh adventitious sound is the bronchial lick squeak. Bronchial from the bronchus. Ang tunog niya is parang merong nagli-leak na sound doon. Listen to that of a sustained Valsalva maneuver. Yung umiire, parang ganon. Yun yung bronchial lick squeak na sound. Anong causes niya? Pleural fistula. Okay? If sound is loud, fistula is small. If soft down, fistula is large. Okay, so we have in the cases of pleural fistula, ano ang adventitious sound? It is bronchial lick squeak, like the sound of Valsalva maneuver. Okay, next we have the voice sounds. So when we talk about voice sounds, gumagamit tayo ng stethoscope pa rin. And then, parang palpation siya, no? I-instruct mo yung patient mo na magsabi ng 99, SSS, stress. Okay? Habang nakalagay yung iyong diaphragm ng stethoscope. Now, itong bronchophony is also known as vocal resonance. Okay? Take down notes of that one. Bronchophony is also called as vocal resonance. So if you hear 99 clearly in the stethoscope, nung sinabi niya na 99 or stress, very audible siya and louder siya, ang pasyente mo possibly ay may consolidation. Okay? So bronchophony is possible in patient with lung consolidation. Okay? Mas clear dahil mas clear siya, mas audible siya dahil daw less ang filtration and yung kanyang attenuation ay concentrated dun sa area. So, mas clear siya kapag consolidated yung area, like in pneumonia. Okay? Egophony actually is part or type ng bronchophony. So, form siya ng ating bronchophony wherein yung spoken syllables na upon auscultation. So, you will ask the patient to say habang nag-auscultate ka. So, this is within the peripheral area or lung area. And then, kapag narinig mo ay through the stethoscope after asking the patient to say Okay? So, tapos, parang ang sound niya is parang nasal sound or may bleating in quality. Parang, parang ganon. Parang ganyan yung kanyang sound. Then that is egophony. So, this is possible kapag ang pasyente natin ay merong consolidation din. So, lahat ito pang consolidation eh. Yung ating pectoral locate, so whispered siya. Auscultate the patient and ask the patient to whisper. 99. So, in whispered pectoral locate, kapag narinig mo clearly ang 99, 99, 99, so that is whispered pectoral locate. Ano ang significance nung spoken syllable na yon na narinig mo clearly? So that means yung ating pasyente ay may consolidated lung area. So clear na maririnig mo yung 99 kapag merong consolidated area. So this is furtherly assessed after the breath sound assessment. Kung nagsususpect ang doctor na merong lung consolidation. Okay? Or, pwede rin yan para sa mga may cavitation. For lung consolidation and lung cavitation. Okay? Hindi natin ginagawa, pero lumalabas sa board exam. Okay? So, a correlated question, what is a stridor? Stridor, of course, sabi natin kanina, ang stridor is an upper airway abnormal breath sounds. High-pitch, musical ang kanyang breath sounds. So this is oftenly heard sa merong viral croup o merong laryngotracheobronchitis. Laryngotracheobronchitis. And usually, kapag merong ganitong stridor, often medical emergency yan. Kaya kailangan nating tawagin kaagad yung doctor. Again, your stridor is the blockage of the throat or the voice box, okay, or the larynx. Okay? Wala. Okay. So yung ating stridor could be due to epiglottitis. So when there is supraglottic swelling, okay, epiglottitis, mag-stridor yan. Kung merong croup, dahil meron siyang subglottic swelling, then makakarinig kayo ng stridor. So ang treatment ng ating mga co-health workers ay racemic epinephrine or sometimes tayo yung nagbibigay topical decongestant racemic epinephrine. Okay, what should the RT do if the patient has coarse crackles, medium crackles, and fine crackles? Sabi natin, ang crackles ay same as your rals. Okay, yung ating rals or crackles ay medyo discontinuous sound siya and loud sound ang intensity niya, and also heard dun sa mga pasyente na merong mucus production. So, ano ba ang gagawin natin? So, the RT should suction or instruct the patient to cough. So, kung effective naman yung kanyang coughing, kaya ng pasyente, then kailangan niyang umubo para matanggal yung coarse crackle sound. Or kung hindi naman siya effective yung coughing niya, then we have to suction the patient. And for medium crackles, then we do the bronchial hygiene. Postural drainage, okay? And then, bronchial hygiene, di ba? From the bronchus ng mga mucus production, kailangan ilabas yon. So, postural drainage, chest percussion, chest vibration. We can also give yung ating breathing exercises and mobilization, chest mobility exercises. And kapag fine crackles naman siya, then we may give oxygen, positive pressure ventilatory support, or kung kailangan, or sa nurse ay magbibigay sila ng Lasix. Okay, so tapos na tayo sa objective findings, and remember that we have done also yung laboratory test, different laboratory test ng RT, ABG, ECG, okay, PFT, sputum testing, yung ating macroscopic examination, not the microscopic. The macroscopic examination for the sputum. What else? Sleep lab test, kung meron yan. SpO2, capnography, hemoximetry, and a lot more. May PFR pa, IS, and others. Now, after doing those, then we'll proceed with the A under SOAP, and that is assessment of RT. You will not assess as a doctor. You're not a doctor. As a nurse, you're not a nurse. as a PT, physical therapist, you're not a physical therapist, that you will only assess according to the limitation and extension of your management. So you may use your laboratory test ABG, PFT, yung inyong ginawang IPA, kung ano yung result nun, chest x-ray, pwede rin from your subjective complaint, magbigay ka ng assessment mo doon through the use of SpO2, hemoximetry, lahat ng laboratory test or special test laboratory na ginagawa ng RT. So example natin dito, so this is the general assessment of RT para sa patient's condition and determination of the cause of the subjective and the objective data. So for ABG, ano assessment natin? There may be acute alveolar hyperventilation. Ano ibig sabihin nun? Acute alveolar hyperventilation with moderate hypoxemia. So by ABG, nakita natin na ang patient natin ay nagre-respiratory alkalosis. Okay? So, pwede sudden yon, and then patient has uncompensated respiratory acidosis kaya. Okay? Ano kaya? That may lead to possible ventilatory failure. So, yan yung sample natin ng assessment ng RT. So, you will not use the diagnosis, asthma, chronic bronchitis, na assessment ng RT. Doktor yon, pang-doktor. For PFT, pwede natin gamitin yan. There's increased airway resistance secondary to severe obstructive lung disease. So kung ano yung result ng PFT, pwede na yon, and pwede nating i-detail or i-rephrase. For the IPA, for example, during inspection, palpation, percussion, patient's difficulty of breathing is secondary to airway irritation. That is already an assessment of RT. Then we may also use yung kanyang chest x-ray result. The patient is exhibiting not the chest x-ray interpretation dahil hindi naman tayo nag-i-interpret talaga ng chest x-ray. We will only know the normal and abnormal chest x-ray. Pero yung interpretation niya, doktor yon, yung radiologist yon, o yung x-ray technician yon. Sa atin, incorporate natin yung terms na ginagamit natin para sa explanation ng condition ng patient. Patient is exhibiting hypoxemia secondary to lung collapse due to mucus plugging. Kasi through chest x-ray, nakita natin na meron siyang radio opacity in the lung area instead na radiolucency. So that means na baka meron siyang mucus plugging or there is lung collapse. And we may also be utilizing the subjective complaint for the assessment. Okay, makaka-form tayo ng assessment dyan using dyspnea is secondary to severe chest pain brought about by heart pump deficiency. Okay, so hindi natin ginamit yung sakit ng patient but dinescribe natin kung ano yung underlying condition na na-assess natin. SpO2, pwede mo rin gamitin yan. The oxyhemoglobin desaturation is possibly due to carbon monoxide poisoning causing shortness of breathing. Okay? So, assessment like that. Next, we have this plan. So, dito na tayo sa dulo. Plan. Ano yung mga plans ng respiratory therapist? So, magdi-design ka ng therapeutic plan, emergency plan, supportive plan, ano kaya ay diagnostic management, measurement para dun sa kanyang general condition o dun sa kanyang ailment. So, pwede ka rin magplano kapag i-discharge na yung patient mo, magbigay ka ng home care program or home care instruction. So, instead na nurse ang magbibigay dahil more of RT, yung tumingin sa kanya at more of RT management, yung during the confinement, then the RT must give the plan, home care instruction or home care plan. O pwede kang mag-clinical recommendation ng RT. Okay. So when you do your clinical recommendation, you will only use all the RT management, the therapeutic, supportive, and emergency management. Okay? So example natin ito. Plan of RT, the RT design detailed therapeutic emergency, supportive diagnostic management for such disease. It may be a home care program or RT clinical recommendation. Example, mechanical ventilatory support via CPAP with 100% FiO2 and 10 centimeter water pit. Okay? So yan yung na-recommend mo sa doktor at tinignan ng doktor kung possible or feasible. Continuous nebulization with Combivent 3 times a day as ordered by the doctor. Okay? Uh, Chest physiotherapy for 10 minutes and do the manual clapping or chest percussion at the right upper anterior bronchopulmonary segment. Okay? Then we may give HIP was endorsed, okay, home instruction program was endorsed to do hourly lung exercise using incentive spirometry with 10 to 15 repetitions each session. So nung pinauwi na yung pasyente mo, dahil post-operative siya, then nag-home instruction program ka, sabi mo dun sa nanay niya, sa relative ng pasyente na kahit nasa bahay, pwede niyo pong magamit pa itong IS. Every hour after waking, dapat maggawa siya ng inhalation or paghigop doon ng 10 to 15 repetitions with breath holding ng at least 2 seconds or 3 seconds. Okay? Or 3 to 5 seconds. Depende sa program mo. Okay? So, as respiratory therapists, again, the art is patient assessment. Wait. Wait lang, sagutin ko lang. Okay, so I hope that you're all okay dahil medyo ano daw yata dyan, pangit yung panahon. Okay, so be safe lang. And while listening or learning here, make sure na safe kayo dyan sa inyong kinauupuan or kinalalagyan. Okay? So the artist patient assessment, the hospital setting, patient assessment. So we have to check on the airway. Airway, ano yung i-check natin? Yung passageway niya. We check if there is obstruction. If the airway is straight. So, chinek natin yung position ng patient, kung tama ba. Baka naman naka-flexion, naka-neck flexion siya lagi, o baka lagi nakatagilid, so that yung airway niya ay hindi straight at hindi siya makahinga ng mabuti. So, we will check the air passageway kung patent siya and without any restriction or obstruction. B for breathing. Yung breathing natin, chine-check natin yung kanyang ventilation, yung kanyang respiratory rate, okay? Yung pattern of breathing niya, yung IE ratio niya, yung use of accessory muscles niya, yung breathing niya ba is without nasal flaring. Okay? Ibig sabihin, effortless or hindi namang hirap huminga. Yung breathing niya ba, together with that, ay nagkakaroon ng paradoxical breathing. Yung breathing niya ba nagkukos ng subcostal retraction, intercostal retraction, or suprasternal retraction. Okay? So lahat ng may kinalaman sa ventilation or sa breathing and respiration. Okay? So aside from the rate, the pattern, and the depth, yung lalim ng kanyang paghinga. Okay? And chine-check natin para dun sa patterns of breathing, yung kanyang mga eupnea ba? Okay? Biots, small, chain stop, etc. Okay? So that is for breathing. And then, followed by circulation. So sa circulation naman, dapat unang-una yung kanyang pulse rate and then yung kanyang heart rate, and then the general circulation ng blood, kung cyanotic ba yung patient mo, may edema ba, may clubbing ba, peripheral, central cyanosis, all about circulation. And then for D, kung susunod na yung letter D is for the disability. For the disability, kung yung level of consciousness niya ay affected, then we can check for the disability. Kung may uh, neurological involvement ba, okay, mayroon bang problema yung patient mo neurologically, kaya hindi makapag-comprehend ng mabuti or makasunod ng mabuti. Okay? And yung letter E is for environmental exposure. So that is for EMS. And then we have the two types of patient, the medical patient and the trauma patient. For the medical patient, dapat in-apply din natin yung OPQRST. And yung for the trauma, na-apply din naman natin yung ABC and the OPQRST. And here it is. Lumabas sa board exam, what is R yata yun? What is R in the OPQRST? What is R? That is radiating area. So OPQRST is the techniques, systematic evaluation or assessment according to O, onset of pain, then P for provocation o yung kanyang aggravating factors, Q for the quality of pain. For the quality of pain, pwede nating i-rate nga 1 to 10. And for radiation, kung nagre-radiate ba posteriorly, okay, nagre-radiate ba inferiorly, nagre-radiate ba doon sa left arm or sa right arm. And then, for the severity of the nung sakit niya. So for the severity, either gaano kagrabe ba yung kanyang gaano kagrabe ba yung kanyang sakit. Pwede rin nating i-rate yan ng 1 to 10 or 1 to 5. Okay? 5 being most severe and less severe yung 1. And then for the time, kumbaga, yung duration of pain, gaano kahaba yung oras na may masakit siyang nararamdaman. At anong oras usually, anong time yung merong intense pain. Ano yung sa time na yon. Okay? So, for the trauma naman, we are also applying the OPQRST, but most importantly, the ABC plus the vital signs. So this is due to accident, yung mga cause ng accident. Okay, so triage is the prioritization of the patient. Pag sa hospital, ang triage mo is kung sino yung nasa ICU, siya yung priority mo. Kung may kasabay yung patient from the ward and ER, so yung ER na patient ang uunahin mo dahil siya yung priority mo or triage mo. Okay? Now, kapag sa EMS naman, yung ating sample, kapag ang pasyente, ang biktima ay nadaganan, nandoon siya sa safe na lugar, yung isa, nandoon sa unsafe na lugar, mahuhulog na sa bangin, so ang uunahin mo doon na triage mo is yung nasa malapit sa iyo na pwedeng makatulong para tulungan yung mahuhulog sa bangin. So that is triage for EMS. Kung sino yung match able and kayang gumalaw, siya yung uunahin mo. Dahil baka later on, kapag lumibo pa o magkaroon pa ng landslide, imbes na buhay siya, nahulog palalo. So unahin mo na siya. Yun lang, kawawa yun nandoon sa bangin. Okay, but that is triage for EMS. Okay, correlation question. For the correlation question natin, what is the first step in patient assessment? And you give it this 3 findings for this first step. So, ano nga ba yung first step natin? Okay, visual examination, di ba? So, upon arrival dun sa room or or doon sa ER o doon sa area, nag-examine na tayo ng patient according to general appearance, sensorium, okay, chest movement, yung posture niya, bed-bound, bedridden ba, skin color, whether in body build, yung attachment or gadgets, or kung merong mga instrument na nakakabit sa pasyente. So that is during visual examination. What is the second step in assessment na ginagawa ng RT? So kasama dito sa second step assessment is yung yan. So under bedside assessment, closer to your patient, you are doing the interview. Okay, you're doing the vital signs monitoring habang nag-interview, inspection, palpation, percussion. Okay, you're checking if ever na meron siyang circulation problem, the capillary refill. Okay, so including mo yung mga interview for past medical condition ng patient mo and the family history. Okay, what is the third step in assessment? So ano nga ba yung third step na to? After ng ating visual examination, bedside assessment, and then yun na, kailangan ng laboratory exam siya using our mga laboratory tests like EKG, ECG, kung tayo ang gumagawa nun. And what is the fourth step in assessment procedures? So, yung pang-apat na gagawin na natin would be special examination. Okay? So, tama ba? Okay. Yung third step is the laboratory. So, sa laboratory test na to, ano yung mga ginawa natin, sinabi na natin kanina? And then for fourth step na assessment is yung ating special examination. For the special examination, aside from the usual ABG, ECG na yan, meron pa tayong ginagawa na MIT monitoring, the maximum inspiratory pressure, maximum inspiratory force, NIF, negative inspiratory force, vital capacity monitoring. Okay, so we may also give IS para ma-measure natin yung kanyang progress, yung pag-expand ng lungs niya will be resulting tidal volume measurement, and then yung kanyang PEFR kung nag-pre and post bronchodilator test siya, or pwede rin na special examination kung mag-sputum collection tayo, ano yung ating nakita dun sa kanyang sputum macroscopic examination. So, yung kanyang quality, yung kanyang odor, consistency or quality, and then yung kanyang amount, and yung color. Okay? So, yan lahat ang ating for special examination. Okay? Now, guys, are you ready for the 60-item exam?